Neurologic disorders. We'll start out with CVA or stroke, a neurologic deficit from lack of blood flow to an area of the brain. There's also TIA, which is transient ischemic attack, which is a lack of blood flow for a specific period of time that goes away, often a precursor to having a stroke. Thrombosis, most common blood clot. It's the most common, which is a blood clot traveling to the brain. An embolus, which is a traveling blood clot, and a hemorrhage, which is a ruptured blood vessel, such as aneurysm, hypertension, often caused because the patient is on blood thinners, Coumadin and heparin. Clinical manifestations. But depends on what blood vessel is involved. Headache is common. Paresis, motor and sensory deficit on one side of the body, nausea, vomiting, aphasia, can't find the right words. Blindness and half visual field, dysarthria, can't speak, dysphagia, can't swallow. Treatment, oxygen, blood pressure control, thrombolytics, if thrombolytics are done within the appropriate amount of time. There is a time limit to this treatment, so that's why early treatment is the best. There is also clipping and coiling. Clipping is the most common surgical treatment for cerebral aneurysm. It involves placing a metal clip on the neck of the aneurysm to prevent rupture. Coiling, which is endovascular therapy, in which a neuroradiologist passes a catheter through an artery and deposits detachable platinum coils in the aneurysm. This prevents bleeding, protects against subarachnoid hemorrhage. So education. What we want to talk to our patients about is reducing blood pressure, teaching signs and symptoms of a stroke. Early treatment is the key. Time is brain tissue. Healthy lifestyle. And you've got to treat the transient ischemic attacks. Those are often, as I said, leading to strokes. Involve families so that they know what to look for, and also they can identify these early symptoms of a stroke. Seizures. What is the definition of seizure? So according to the National Institute of Health, a seizure is a physical finding or change in behavior that occurs after an episode of abnormal electrical activity in the brain. What the body does after the abnormal electrical activity in the brain, basically. Types of seizures. I have this organized in partial or generalized. So partial means simple partial or complex partial. Generalized is absence seizures, where the person just appears like they are spacing out for a period of time. Tonic-clonic, which is what you're thinking of when lay people think about a seizure, the jerky movement, that's what it is. Myoclonic is a kind of a more constant jerky movement, and atonic is the lack of muscle tone. Partial seizures. Complex, which is they originate in the temporal lobe, the repetitive non-purposeful movements, impaired level of consciousness, and aimless walking. Simple, it's limited to one hemisphere, so this is not what people think of as a typical seizure. Generalized seizure. Type, general tonic-clonic, unconscious, convulsions, muscle rigidity, absence, brief loss of consciousness. Myoclonic, sporadic, jerky movements. Clonic, repetitive, jerky movements. Tonic, muscle stiffness, rigidity, and atonic is loss of muscle tone. Seizures. Prodromal phase. Prior to the seizure, you may feel it coming on. Oral phase is when, prior to the actual seizure, they have an aura, or they sense an aura. Ictal-phase is the actual seizure. Manifestations are seen. That's when things happen. Post-ictal phase, it's after the seizure. They feel tired. They feel weak. They may want to sleep. So nursing care, note the onset. Evaluate the movement so you can better evaluate the seizure. Protect the airway. Remember, airway, breathing, circulation. Position, place on side. Patient safety is what we're worried about there. And teach medication adherence. So oftentimes people go off their medications, and that's when the seizure happens. Therapeutic management, anti-seizure medications. So you monitor the serum levels. They have to be These medications just can't be taken daily without checking. They have to be monitored for blood levels. So the Dilantin, the Tegretol, and the Depakote all have to be monitored. And they can have toxic effects if they get too high. So you have to avoid alcohol and limit the caffeine. Status epilepticus can be fatal. You have to protect the airway, and you have to stop the patient from seizing. Ativan, lorazepam is one of those medications that can do that. Traumatic brain injury, either open or closed. So this would be a penetrating brain injury. Open head injuries, linear skull fractures, depressed skull fractures. Open skull fractures or a basilar skull fracture are the 4 different kinds. Basilar skull fractures, you have to watch out for clear nasal or ear drainage, because then that's what you're looking for is CSF fluid, battle sign, and raccoon sign, so bruising around the eyes or behind the ear. Closed head injury, concussions, signs and symptoms: brief loss of consciousness, amnesia, headache, post-concussive syndrome, persistent headaches, lethargy, personality, intellectual changes, and decreased attention span. Brain contusion, you may have a coup or a contra coup injury. What happens inside your skull is your brain actually hits the front of your skull, and then it bounces back and hits the back in a counter coup, causing a contusion. All of these can cause cerebral edema. There's only so much space inside of your skull. So you have brain tissue plus blood plus CSF, and that takes up the total amount of space. If your brain tissue swells, you have less room for blood and less room for CHF. If it swells too much, then no blood is allowed in there. Cerebral perfusion pressure equals the mean arterial pressure minus the intracranial pressure. So once that pressure reaches too high, that's when you start to have brain cells die. It's normally an auto-regulation, but if it becomes to the point, your mean arterial pressure can only raise so high. So if it gets too high, you no longer have blood perfusion. You're no longer able to get blood perfusion to the brain. Assessment for edema. Level of consciousness is the first sign, the earliest sign. Pupil dilation is normally, or changes in pupil dilation is normally the last. So the first things you're looking for is a change in the level of consciousness, orientation, motor, or possibly vital signs. Diagnostic tests, CT scans of the brain, EEGs, ABGs, electrolytes, CBC, osmolality, and possible lumbar puncture if you're looking for meningitis or other things affecting cerebral edema in the brain. Monitor sodium levels. Low sodium, salt wasting syndrome, you would be giving 3% sodium. High sodium, which happens in diabetes insipidus, you're giving half normal saline to correct the electrolyte imbalances. Intracranial pressure, you're looking for CSF leaks. Make sure the head is up, body in neutral alignment to prevent any kinks into the flow of the CSF. Control the carbon dioxide pressure in the blood. That's an acid. You don't want to become too acidic. It causes more swelling. Prevent hypoxia, because that causes more edema as well. Suction airway, you have to be very careful, because that can increase intracranial pressure just in itself, so you have to be very careful. And sedation, you don't want somebody anxious or in pain. Both of those will increase intracranial pressure. If they're intubated, you want to have paralytics. You even may want to keep them in a barbiturate coma, just so the intracranial pressure and the mean arterial pressure are both decreased. Consider diuretic therapy. That decreases the overall fluid volume. You need to prevent hyperthermia. That increases edema. You need to manage the osmolality to make sure the electrolyte balances and the osmolality of the blood stays stable. And consider ventricular drainage, which is a hole or a shunt to reduce some of that fluid or take off some of the pressure. spinal cord injury, prevention is the key. Common areas injured is the neck, and we'll go through some more of those. Types of lesions, we won't get into all of the details. I just wanted you to see that there could be a complete tear in the spinal cord or different kinds of incomplete tears, central cord, anterior cord, and some other ones. Initial assessment and care, make sure you stabilize the neck and the back, okay? Get that C-collar on there, make sure they're not twisting to cause further injury. You have to watch for respiratory failure if we're looking at a C2 or 3. C4, there's only very partial respiratory ability. You need to assess for motor signs, assess for sensory signs, watch for incontinence and pain. For ongoing assessment, airway, breathing, circulations, you go back to the basics. Look for bleeding, monitor the Glasgow Coma Scale, and do continual neuro checks, which are motor and sensory status. The Glasgow Coma Scale is a kind of a fast scale that you can use to determine level of consciousness. There's scores for eye opening, verbal response, and motor response. So the thing about this, if you have a Glasgow Coma Scale of 3, you could essentially be dead. You have no eye opening, you have no verbal response, and you have no motor response. So you have to be careful if someone says they have a Glasgow Coma Scale of 3. It's not a good thing. Collaborative management for spinal cord injuries, Solumedrol. You're looking at decreasing inflammation, and that's what the Solumedrol will do, is an anti-inflammatory. You may consider traction. Make sure that you do a log roll so you don't twist the body or twist the spinal cord, and treat spasticity and pain. For circulation, make sure that you treat bradycardia. Make sure you treat hypotension. You need to have that pressure, enough pressure in the blood vessels to get the pressure to the brain. You need to keep a fairly stable blood product fluid, so you can use blood products and other fluids to maintain that fluid balance in your body. Watch for vasovagal responses, and as I was saying, monitor your fluid and electrolyte imbalances and promote blood return. Collaborative management, oxygen. Lesions above C4, you're going to have some kind of respiratory support, usually intubation. Pulmonary toilet, which means keeping the secretions out of the lungs. Aspiration preventions, you need to keep that head of the bed up, and bronchodilators to help with the breathing status. The other thing for nutrition is you often, with spinal cord injuries, have paralytic ileus and the inability of the small intestine and large intestine to function. Some parts of it just shut down. Stress ulcers, you might want to consider histamine 2 blockers, total parenteral nutrition if the GI tract continues to have an ileus, and constipation is always an issue with spinal cord injuries. Skin tissue integrity. Consider kinetic beds that move, beds that will turn the patient for the patient so they can get some pressure off some of the bony prominences. Inspect the skin. You look at the coccyx, the heels, the back of the head. Make sure you have protective devices. They're unable to move themselves, so every time they move, it'll have to be you doing it for them. Psychosocial care. Go over what to expect. This is a big change in their life. It's the biggest change in their life they probably have ever had. So you never want to give up on hope, and continue with the reassurance. You need to make sure, though, that they are able to verbalize their feelings. That's therapeutic communication. Let them talk about that. It's always be a fear of the unknown, so make sure you're very accurate on what you and the physicians have figured out what the patient can and cannot do. And offer stimulation. For bacterial meningitis, so bacterial infection of the spinal cord or brain, you're going to have nuchorigidity. You're going to have a very stiff neck and the inability to move it easily. In fact, there is two tests to determine if, kind of a screening test for meningitis. Brzezinski's sign is severe neck stiffness causes the legs to flex when the neck is flexed. You bring your neck up, your legs come up. Chronic sign, inability to straighten the leg when the hip is flexed. Put your leg up, you cannot straighten it out because it is so stiff. Signs and symptoms, chills, high fever, vomiting, other signs of increased intracranial pressure, photophobia, petechial rash, diplopia, seizures. Diagnosis is increased pressure of the CHF, increase in protein, and decrease in glucose of the CSF fluid. High white blood cell count. You can do blood cultures and sodium levels. So the things you want to do is assess for neurologic deterioration, respiratory isolation for 24 hours to make sure that you are not contaminating other patients. Seizure precautions, consider antibiotics. Make sure it's a dark, quiet room. They will have headaches, and you'll have to really watch the hydration status. You need to monitor for complications. So you can have septic emboli in circulation. They'll end up in the hands, cutting off blood supply, causing major issues with being able to keep blood flow to that area, causing necrosis. You can even go into septic shock. There's a strong coagulation disorder component, and they can have prolonged temperature elevations. Parkinson's disease. One of the main things that you will notice is a bradykinesia, so a very slow movement, muscle rigidity, a stooped posture, kind of a shuffling, kind of propulsive gait, and a tremor. Collaborative care, you need to increase the dopamine. So the medications that you'd be giving are medications to increase dopamine supply to the blood, levodopa, carbidopa, some other medications. Nursing care, you need to consider and assist mobility, assistive devices. Make sure that they're not a fall risk. Make sure they're getting enough nutrition. They have difficulty with controlling their swallowing reflexes, so aspiration precautions and any other assistive devices. Alzheimer's disease is a chronic, progressive, degenerative brain disorder affecting memory, cognition, ability to care for themselves. There are some medications that decrease symptoms and decrease progression of the medication of the disease. Aricept is one of the most common. Nursing care is cognitive stimulation. Keep that brain going. Make sure that they have activities. Make sure they have stimulation, things to do, things to think about. Although you need to have a structured environment, so make sure that they have a routine and they have the safety of an area that is free of basically things that are going to harm them. They may not be in a state of mind in later stages to even protect themselves. You need to provide consistency, promote independence as much as possible, and promote bowel and bladder continence, because once the incontinence sets in, you have all kinds of pressure ulcer, bed sores, and skin problems to deal with. So some things they need help with are also assistance with facial recognition. You need to promote communication with these patients, attract the patient's attention before talking, avoid environmental distractions. They can't have too many stimuli at once. Speak directly to patient, distinctly in a clear, short sentences, as if you would talk to them as if maybe English wasn't their first language. You would be talking to very slow and deliberately. Ask patient to perform one task at a time, giving plenty of time and breaking down into small steps. Myasthenia gravis, varying levels of generalized weakness, extraocular muscle weakness, diplopia, one eye that droops, weak eye closure. The diagnosis of myasthenia gravis is acetylcholine receptor antibodies in the blood. This is a autoimmune neuromuscular disease that has affected the acetylcholine receptors, and so if you have the antibodies, that's one of the diagnostic tests. CT scan, so you're looking to give IV tensilon and histamine, which is anticholinesterase, and EMG. Collaborative management. Certain medications can assist. There's always issues with cholinergic crisis. Cholinergic crisis is over medication. Myasthenic crisis is under medication. So both of them, though, can cause respiratory problems, respiratory distress. Guillain-Barré Syndrome, ascending weakness, causes acute respiratory failure. On occasion, it can be a descending weakness. Management, immunoglobulin plasmapheresis, which is a form of dialysis which removes antibodies from the blood. Make sure you give them respiratory support and communication. Multiple sclerosis manifestations, fatigue, weakness, leg spasticity, and tension, tremor when you go to do something. You have that shaking. Ringing in the ears, dizziness, hearing loss, vision changes. So decreased sensitivity to pain. You have paresthesis, facial pain, decreased temperature sensation, numbness, tingling, burning, or crawling sensations. You're often anxious with emotional liability. Management, medications to delay or decrease exacerbations. Physical speech therapy, warm pack stretching for the muscles, trying to minimize fatigue, and teach fall precautions. So that is it for this session. Thank you.